Here at the meeting, I have presented some new data on the use of monoclonal antibodies for the treatment of patients with myeloma. In fact, two drugs were recently approved at the end of 2015 in the US, and these two drugs also received a favorable opinion from the CHMP, so from the European authorities, and they will be probably approved for the treatment of myeloma patients as well in Europe very soon. One of these two drugs is elotuzumab, a monoclonal antibody targeting SLAMF7. SLAMF7 is always expressed by the tumor cells, so it is a good target. And elotuzumab was tested in a randomized trial comparing lenalidomide and dexamethasone, that is one of the standard of care in relapse, versus lenalidomide, dexamethasone plus elotuzumab. And this study in patients with 1 to 3 prior lines of treatment showed that the addition of elo is improving the duration of the response, progression-free survival, and there is also a big trend in favor of better overall survival with the addition of elotuzumab. So this triplet combination with lenalidomide, dex plus elo is a very interesting one, and will be probably widely used, in fact, for myeloma patients. Importantly, the efficacy is good, but also the safety profile of elotuzumab is very good as well, since we do have a very little toxicity associated with this drug. The issue with elotuzumab is that we are using this drug until progression, in fact, with an IV infusion. So some patients are going to stay very long on treatment, so it means that they have to go back frequently to the hospitals twice per month, in fact, to receive this IV drug. And the second monoclonal antibody that was developed and approved in the US and will be approved in Europe as well very soon is daratumumab. Daratumumab is a monoclonal antibody targeting CD38. CD38 is always expressed by the tumor cells as well, so a very good target. And daratumumab has a single agent activity and was developed in very advanced patients. Patients progressing on IMiDs, progressing on proteasome inhibitors, patients in the situation of unmet medical need without any other treatment possibilities. So DARA in this situation is inducing 30%, 31% of response, at least partial response, and also is able to control the disease in 50% of the patients. These patients are not progressing, they have either a minor response or a stable disease. And in these two groups of patients, those with a partial response and those with a stable disease, there is a clear benefit in terms of overall survival. These patients are able to live 1 or 1.5 additional year. That is very good, in fact, when the patients have no other possibility of treatment and they have exhausted all the available agents. So daratumumab was approved in the US, is widely used, and will also be combined with many other regimens, in fact, and we are probably in the future going to use DARA in combination with lenalidomide and dex, in combination with bortezomib and dex, and probably also as part of frontline treatment, especially in patients treated with stem cell transplantation. So we have two important drugs, elotuzumab and daratumumab, that will come on the market very soon in Europe. The issue is the best option for a specific patient because all these drugs are developed in phase 3 trials. Elotuzumab was developed in combination with Lendex. Daratumumab is also developed currently in combination with Lendex or with bortezomib dex, not only as a single agent. So it will be rather difficult in the near future to choose or to select the optimal option for a specific patient. We will have, for example, Lendex carfilzomib, Lendex elotuzumab, Lendex ixazomib, Lendex daratumumab, and right now we don't know exactly what subgroup of patients is benefiting most of one combination versus the other. So we have a huge work to do to try to propose the optimal option for the one specific patient. Of course, we have to balance efficacy with safety, with convenience, with cost, also according to the comorbidities of the patients, frailty, quality of life also has to be considered, obviously. So we have a lot of work to do to define the best option for one specific patient. No, in fact, the monoclonal antibodies are not compared one to the other. We don't have any comparison of ELO versus DARA, and this study won't be performed. I think that we have to analyze clearly all the data that are available carefully, and this is the role and the goal of this international myeloma working group, to try to define and to propose reliable algorithm of treatments, in fact. So that's what we are going to do in the near future. We are trying also to define what is the high-risk population of patients, what is high-risk smoldering myeloma, because we can also try to treat patients very early on in the course of their disease when they have a true myeloma, but with a low tumor burden. So we have to build clinical trials aim of curing some patients. So we have plenty of things to do. Well, the take-home message is, we need to use these drugs. We need to use these drugs carefully, because some of them are associated with a specific toxicity. We also have to try to be well balanced and regarding the optimal use. Once again, what is the optimal combination for one specific patient? This is the most important question to be solved in the near future.